prostate capsule sparing cystectomy. Arguing in favor of that is Laurie Klotz. Arguing against it will be Mark Soloway.
Thank you. Another minefield, I would say. And in fact, I got interested in this operation because of my exposure to Yoni Pintas when he was my fellow, and started doing this with him and have continued to, and I think there's a very good case for it. This is Willard Whitmore, who was my mentor. Radical cystectomy may be the gold standard, but don't cast it in stone. Keep an open mind. The potential advantages to improve the functional outcome, simplify the procedure, preserve the neurovascular bundle and external sphincter complex. If you are leaving the prostatic capsule in particular, these structures are not at risk. Make the cystectomy more acceptable to patients and do this without compromising cancer control. So the concept is to take the bladder and the prostatic adenoma, leave the capsule. The nomenclature is a bit confusing. Most people who write and talk about prostate sparing actually mean prostate capsule. So the norm is to remove the adenoma, which contains the vast majority of the prostatic ducts that are at risk for urothelial disease. Spare the apex variably. And the concept is to do a kind of Millen prostatectomy where you remove the capsule with the adenoma with a combination of sharp and blunt dissection, leaving the capsular structures that have the nerves and muscle that you want to preserve. And that leaves a kind of shell of capsule. The adenoma is usually attached to the bladder. And part of the appeal here is it makes the anastomosis quite simple, because instead of, this goes along with a neobladder, instead of suturing to a small urethral apex, you have a broad area with a lot of tissue. The sutures hold very well. Exposure is quite easy. So, and typically this is done with either a Studer or some type of orthotopic neobladder. So, first of all, why is quality of life, can it be improved with the traditional cystoprostatectomy? In fact, in the real world, erectile dysfunction is reported in about 60%, nocturnal incontinence 25% or more, strictures are not rare, retention is not rare. So, the concerns about this approach, and I'm sure we're going to hear about this from Mark Soloway, the risk of prostatic urothelial involvement, of leaving prostate cancer behind, and is there a rate of local recurrence? So first of all, the issue of prostate cancer, about a third of patients will harbor prostate cancer. This goes back many years, certainly to the STAMI data, depending on how hard you look for it. But in fact, most of these are not clinically significant. Perhaps 20% would be called clinically significant by STAMI criteria. There's really no convincing evidence that prostate cancer occurs at a higher rate in patients with bladder cancer having a cystectomy. And in fact, the evidence suggests that if you look for it preoperatively, you select out the patients who have an elevated PSA, perhaps free versus total PSA, you do a biopsy if prostate cancer is suspected. The studies that are out there, admittedly small numbers, but you look that absolutely none of them have had clinically significant prostate cancer defined as more than 0.5 cc's of Gleason 6, or higher, or any Gleason 4 or 5, 0 out of that approximately 200 patients. What about prostatic urothelial involvement? Again, this is not so uncommon in an unselected population. Somewhere around 20 to 50% will have at least some prostatic ducts or urothelium involved. Stroma invasion is considerably more uncommon. But again, the evidence suggests you can identify these. So this is Seth Lerner's work published a few years ago, 128 specimens, and he looked at what is the prevalence of prostatic involvement and who are these folks. So about 40% had some prostatic involvement, but the vast majority were detected by either prostatic urethral biopsy or by digital rectal exam. So again, the patients, if you are stringent about evaluating the prostatic urethra preoperatively, you can find the ones who have prostatic urethral involvement in the majority of cases. And then the proof of the pudding is that the incidence of local recurrence after capsule-sparing prostatectomy is exceedingly low. So here you can hear this summary of prostate-sparing cystectomies, almost 500 cases, 3% local recurrence, which is arguably certainly no worse and possibly even better, reflecting the selection that's going on compared to a cystoprostatectomy case, and about 12% with systemic recurrence, 2% with prostate cancer, putting all these cases together. The overall survival, of course, you're comparing series, but just the general trend, this is compared the Valencian, one of the larger series, to the Stein series, and basically you can't draw any conclusions about a difference in survival based on the data that's out there. There certainly doesn't look like a difference. One approach that used is actually a seminal vesicle sparing with the goal of maintaining fertility, and in this series from Muto, there was considerable success at maintaining fertility and no evidence of an adverse effect. And then you move on to the functional results, and this is where it really looks compelling in my opinion. Continence, 95 to 100% continence reported in these many series. The patients are younger, not surprisingly, but even so, I maintain that the kind of sky-high look at this data is pretty compelling, that continence is better in patients who have a prostate capsule-sparing cystectomy than certainly my previous experience with complete cystoprostatectomy. Some patients require intermittent catheterization, but I think most of us would acknowledge that a patient's better off on IC and dry than incontinent. And potency sparing, also very compelling, 80%, 90%, 100% potency sparing. And again, you are nowhere near the neurovascular bundle. You're simply resecting adenoma. Arguably, the figure should be about the same as patients having an open simple prostatectomy. The series go back about 15 years. This is just the most recent one. I'll just show it in a little more detail. One of the criticisms of the earlier studies was that the follow-up was limited. You can see typically 2 to 3 years. So this study now, 6.5 years. It's from Hornblas's group in Holland, 120 patients, 5-year disease-specific survival, 66%, 10% local recurrence rate, very consistent with traditional rate of local recurrence after radical cystectomy. Only 1 local recurrence in the remnant prostatic urothelium. So that arguably is the one patient who has been disadvantaged by this approach. 3% with prostate cancer, 96% daytime, 82% nighttime incontinence, and very high rate of erectile function preservation. This is the kind of algorithm that's been described for managing these patients. So initial staging assessment, TUR of the bladder neck and prostatic urethra, a frozen section at the time of cystectomy, PSA, DRE, and arguably ultrasound and sextant biopsies. I don't do that unless there's some reason to suspect prostate cancer, but some people do that routinely, and you exclude the patients who are at high risk for prostatic urethral involvement by virtue of either a tumor right at the bladder, neck, and urethra. In my opinion, trigonal involvement is not a reason to exclude them, or prostate cancer. They would have a cystoprostatectomy, otherwise capsule sparing. So there's basically two approaches to this. There was what I would call the more conservative approach, where you take potent patients, normal DRE, negative prostatic urethral biopsy. The biopsy should be done near the viru, where the ducts are more concentrated, negative surgical margin at the apex. Let me just go back. But to my, so these would be the more inclusive approach, or a more stringent approach, taking only T2s, patients who don't have disease in the trigone or bladder neck. That obviously excludes a lot of patients, and no multifocal CIS. Remember, you're taking the adenoma that's got most of the ducts. So my approach is to offer bladder sparing to a very significant number of patients. And I believe, based on the published data and my own experience, that this produces an improved functional result. Patient selection is criteria. Patient selection is critical. It's not for the patient with a high risk of local recurrence or large volume, high stage disease. But the evidence suggests that overall survival recurrence-free rate is the same, and that they have an improved functional results, and it's an easier operation. Thank you.
Lori, give me a break. A few minutes ago, you made my life even easier. You just criticized Dr. Sandler for a few patients that you said bladder preservation can't possibly be as good because you're going to have the occasional patient with later cancer. That was terrible. And he's preserving potency, and he's allowing patients to void better than either an ileoconduit, they can't void at all, or a neobladder. So you've just criticized him, and now you say, well, you have all these possibilities for understaging problems, which I'll very quickly elucidate, but you're willing, on these patients, younger patients, to take the risk of their life. Well, so I think you've already lost the argument, Lori, and I'll just hammer it in a little bit more. But again, you and I are quite different. You live in the cold and the rain up in Toronto. I live in sunny Miami. You spell tumor with the U. I just say T-U-M-O-R. And there are a lot of you like chocolate. I happen to like vanilla. You play hockey. I play basketball. So we have, you picked the team here, and you lost this one. At any rate, as you know, urothelial carcinoma of the prostate is not uncommon, and this is a very lethal cancer. We're not talking about adenocarcinoma of the prostate. If you make a mistake in judgment here, the patient's going to die. So you have no possibility to make an error. And we know that I don't care how many biopsies you do on the front end, you're occasionally going to understage this. And if you understage a patient with tumor invading into the stroma, that is a lethal mistake. And so we all know the data. It goes back to David Wood, this nice paper, Journal of Urology, 1989. And again, predictive factors, 717 men with cystectomy. This is at the Fondation Puigvert. 20% had tumor in the prostatic urethra. So it's a very common problem. And so therefore, you said it, tumors at the bladder neck, more invasive disease, anything in the urothelium. Where I work, that's a very high population of our patients. And that's again why actually I wrote an editorial, Dr. Sandler, that very few of our patients, although I think bladder preservation is a great idea and works for the right patient, that's about 5 or 10% of the patients that I see in our area. Pre-op prostate biopsies, and this is reported from Columbia, 50% they use cold cup, 40% TUR, 35% of the patients had tumor in the prostatic urethra. So this is a relatively common problem. Prostate-sparing cystectomy, limited data, and you absolutely are right. There's very limited data. It's relatively infrequently done. Here's a large series, 160 patients, local recurrence 5%. I think that's too high. What are you going to do if you have a local recurrence? Now you have to salvage, use radiation therapy in the area. You've got bowel down there, either whether you did a neobladder or an ileoconduit, there's bowel right in the recurrent area, and I'm sure Dr. Sandler is one of the radiation oncologists here who would rather not have that task. He's going to limit a dose. So how to investigate pre-op rectal exam? Yeah, you can do it. It's not very accurate in adenocarcinoma. It's not very good in urothelial carcinoma. PSA, sure, and you're probably going to have to do some biopsies, so put the patient into more cost, et cetera. Risk versus benefit, and this is really where it comes down to it. Now, first of all, parenthetically, I think the neobladder is terrific, but over the past 10 years, the likelihood of a patient having orthotopic neobladder is going down dramatically. And I was just reminded of this recently. I shared a patient with the current chief of urology at the University of Miami who was going to do a robotic cystectomy. He's a very good robotic surgeon. And he did not even offer the patient ileoconduit. He just, an orthotopic neobladder. And this is a fit guy who was pretty motivated to consider it anyhow. He just said the complication rate is too high. I offer you a ileoconduit. And I did a neobladder on the patient. He's done fantastically well. And that's just an example. Cheryl Lee tells me at the University of Michigan, an outstanding, superb institution, only 20% of their patients have an orthotopic neobladder. All right, continence. Yes, you're probably right that nighttime continence would be better if you preserve with your capsule, sparing leaving in that part of the prostatic capsule. So I'll grant you that. I don't think CIC, for example, if a patient is totally continent and can't void with a CIC, that's not so bad. Patients adjust pretty well. I don't look at continence as a huge problem, except incontinence at night is a problem, so that might be a little better. As far as potency, again, you're absolutely right. But it gets back to the same argument. I think you are going to have some more recurrences. I agree prostatic adenocarcinoma is not the problem. The problem is urothelial carcinoma. And if you leave that behind, that's a major issue. So the suggested patients, obviously you have to inform the patient. We both would agree younger patients would be the best for this. Patient has a very strong desire for potency. Possibly some people even talk about ejaculatory function. Personally, getting back to the potency issue, I agree with Richard Hauptmann that preserving the seminal vesicles, actually, and staying away from the nerves in that area as well, leaving the seminal vesicles in the patient. Again, there's a slight risk in that, but that helps with potency. The patient, I think, should have only TA or T1 urothelial carcinoma with your procedure. T2, T3, I would not consider it. Should have a normal PSA, negative rectal exam, negative prostate biopsies. That's a tough list. Not a candidate, all would agree, urothelial carcinoma of the bladder, neck, and trigone. That's right away at least 80–85% of our patients. So the issues, little room for error in radical cystectomy urinary diversion. Our staging, despite MRI, PET scans, you name it, is not very good. We understage tremendously. Chemotherapy and radiation therapy is often not curative afterwards if you have a local recurrence. I agree adenocarcinoma of the prostate is frequent, but that's not the major issue. Remember, however, that the most likely place for adenocarcinoma of the prostate or a common place is at the apex. Urothelial carcinoma of the prostate, we've already talked about, is relatively frequent. So my view, very few of my patients are excellent candidates, as you outlined, for prostate-sparing cystectomy. It adds some uncertainty. Monitoring will become a little bit more complex, and most importantly, this is an operation, first of all, that is only, I'm talking about radical cystectomy and diversion. It's an operation that I think is one of the more difficult in all of urologic oncology specialty because of the complication rate being 50% at the best institutions. And it's going up. The more you look at the different system, a transfusion's a complication, et cetera, you have to tell your patient you have a 50–60% of a complication, and now you're going to potentially add to that in terms of the possibility of subsequent treatment. So I never want to be considering reoperating on any patient. We'd perform a cystectomy and diversion, and this adds one little area of uncertainty. Thank you.